Hello and welcome to this pathophysiology video on lung cancer. So before we get started, let's check in and see what you already know. So question 1. A patient is suspected to have lung cancer and their blood results show hyponatremia, which is low sodium. What is the most likely diagnosis? So here to help with this question, have a think about paraneoplastic syndromes. So the answer is small cell lung cancer. So small cell lung cancer is commonly associated with these paraneoplastic syndromes, one of which involves the production of ADH, which would therefore lead to hyponatremia. Question 2. A non-smoker has been diagnosed with lung cancer. What is the most likely type of lung cancer he's been diagnosed with? So only one type of lung cancer has a lower correlation with smoking than the others, and that is adenocarcinoma. Question 3. A patient with a performance status of 3 is most likely to be able to what? So remember, performance status is used by the World Health Organization as a way of assessing the patient's level of functioning, and it can be used in deciding management of a patient as well. So the answer here is limited self-care. Got all of the options up in the top corner there from 0 to 4 for performance status, and we'll be covering it later on as well. So what we're going to cover today, well, we'll take a look at lung cancer and its definition and the different types of lung cancer and how they come about. Have a look at the symptoms and the clinical history and investigations that you do, and then finally we'll take a look at management in very brief terms as well. So lung cancer, of course, is carcinoma of the lung, and approximately 95% of primary lung tumours are bronchial carcinomas. Now, commonly as well, other tumours metastasize to the lung, and these are from other primary tumours including from the kidney, the prostate, the breast, bone, GI tract, cervix and ovary, so pretty much most cancers can metastasize to the lung. Unfortunately, lung cancers do have a fairly poor prognosis, generally speaking, unless caught extremely early, and often, unfortunately, they're not caught that early because the symptoms are quite non-specific. So lung cancers can manifest, as we said in the questions before, as a paraneoplastic syndrome, which would lead to symptoms that you may not expect normally with a disease of the respiratory system, and we'll cover some of these in a second. So the key thing with lung cancer is understanding how it's split up, and generally speaking you can break down lung cancer into small cell and non-small cell lung cancer. The majority of cases that you'll see in hospitals are non-small cell lung cancer, making up 85% of the total workload, which can further be divided into squamous cell carcinoma, which are the most common, followed by adenocarcinoma, which are the second most common. Following that, you've got these 3 types of cancer here: large cell carcinoid tumours and bronchoalveolar. Bronchoalveolar is a term no longer used, however, putting it here just in case you do see it in clinical notes, which you probably still will. And these 3 are much less common, as you can see, 8%, 7% and 4% of non-small cell lung cancers. Squamous cell, adenocarcinoma and small cell lung cancers are by far the most common that you'll see on the wards. So let's break it down and have a look at what a small cell lung cancer is first. It's also been called oat cell carcinoma, and they arise from cultured cells. They tend to be rapidly growing and they're highly malignant, so they spread early and are almost always inoperable when they present. The good thing is they respond to chemotherapy, however, even with this, the prognosis is still poor, unfortunately. Now, small cell lung cancer is what we were talking about as manifesting as a paraneoplastic syndrome. So there are several ways it can do this. It could produce ADH, which would lead to hyponatremia, low sodium. They can produce ACTH, which would lead to Cushing-like symptoms. And it can also produce Lambert-Eaton syndrome, which would cause the myasthenia-type symptoms. Moving on to the non-small cell lung cancers, firstly we have squamous cell carcinoma. These are most commonly associated with smoking, and they often present as an infection due to an obstructive lesion of the bronchus. Local spread with these is common, but widespread metastases are fairly late on in the prognosis, so if you catch this early you have a better chance of dealing with this successfully, and as we said before, they're strongly associated with patients who have got a strong smoking history. Next we have adenocarcinoma. Now, adenocarcinomas are kind of the opposite of squamous cell in the respect that you associate these with people who are non-smokers. They arise from mucous cells in the bronchial epithelium, and are the most common bronchial carcinoma associated with asbestos, and therefore, as a result, is most commonly associated in non-smokers. Invasion of the pleura and mediastinal lymph nodes, however, is common with these, and it often metastasizes to the brain and bones. Next we have large cell, certainly less common at only 8% of diagnoses. They're less differentiated forms of squamous cell and adenocarcinoma, but don't fit into the small cell lung cancer either. So these metastasize early, and often therefore the prognosis isn't great. In the past, about 10% of lung cancers were classified as large cell, but we now classify them much lower down, so as low as 2% it says here, because we're getting better at diagnosing each of the other subtypes of lung cancer. And to be clear, large cell can be found anywhere in the lung, although it's most common found in the periphery. Carcinoid tumours, even less common. So a lung carcinoid tumour is a type of cancerous tumour made up of neuroendocrine cells, and these cells are of course found out throughout the body, but including in the lungs, and they're similar to endocrine cells because they produce hormones and or hormone-like substances, but in other ways they resemble nerve cells because they secrete neurotransmitters. And sometimes they grow too quickly, and this is what causes a small tumour known as a carcinoid tumour. The advantage to these are they're slow growing, but they are rare and they rarely spread beyond the lungs. Next, you've got bronchoalveolar cells. So this is a term that's not really used anymore, and this type of lung cancer is now considered a subtype of adenocarcinoma. It's relatively rare, and it arises predominantly in the lung periphery and grows along the alveolar walls without destroying the lung parenchyma itself. Now, in general, the prognosis for these is much better than other types of non-small cell lung cancer, especially when it's caught early and if there's only one tumour present. So moving away from talking about the different types of lung cancer, which is quite a lot to get your head around, it's important then to recognise some of the symptoms that patients may present with, which would alert you to a diagnosis of lung cancer. Now, what's important about these symptoms is, yes, you may see these symptoms in a patient who has got lung cancer. However, it's quite difficult to pick this up in primary care. As a result of these symptoms can be fairly non-specific and can point you towards an alternative diagnosis. A lot of lung cancers, generally speaking, are found incidentally on a chest x-ray when a patient's in hospital, and then they go on to have CT scanning and so on. These symptoms, of course, lots of these together may increase your suspicions, and it's important to recognise also the symptoms of metastases as well as the symptoms of the paraneoplastic syndromes we talked about earlier as well. So, of course, risk factors for developing lung cancer: active or passive cigarette smoking is, of course, a major risk factor. Naturally, you're more likely to develop lung cancer with increasing age because if you've smoked for long, you've got a greater pack year history of smoking, and you're more likely to develop a lung cancer. So people with COPD, arguably this is because these are patients that have got a strong background of smoking, but also there's some new evidence that potentially suggests that they have some kind of genetic predisposition to it as well. So people with a previous history of cancer, especially head and neck, are more likely to get lung cancer. And those who've worked in the industry of dust, asbestos, chromium, arsenic, iron oxalates, and radiation, so different metals which are linked to lung cancer as well. There's also evidence that the epidermal growth factor receptor and its ligands are frequently expressed in non-small cell lung cancer as well. It's also important to recognise these symptoms which may indicate lung cancer in certain locations within the lung. Horner syndrome with eyelid drooping and a dry eye. SVC, superior vena cava obstruction, which would result in a swollen head and swollen arms and gouged neck veins. A phrenic nerve palsy, which would result in a paralysed diaphragm, and the C345 keeps the diaphragm alive. Dysphagia, so the inability to swallow or difficult swallowing, and left recurrent laryngeal nerve palsy, leading to a hoarse voice. This could be due to the location of a tumour compressing, for example, the laryngeal nerve, leading to a hoarse voice, which is what you detect in clinic. In terms of examination, of course, respiratory examination is what you'd carry out, but it may be entirely normal in a patient with lung cancer. Also, you may notice peripheral stigmata of respiratory disease, including finger clubbing and tar staining or other things that point you towards a patient who has been a heavy smoker in the past and then has maybe developed this as a result. This is, of course, a later stage complication of lung cancer, HPOA, which results in inflammation of the bones in the wrist. And essentially this would only be a later stage manifestation and should alert you to a potential lung cancer. As well as this, it's important to recognise the signs and symptoms of metastatic disease if it's spread from the lungs, including bony tenderness, hepatomegaly, confusion, fits, focal neurological deficit, cerebellar syndrome, proximal myopathy, and peripheral neuropathy as well. So how do you investigate a patient with lung cancer? Well, first of all, the GP, if they have their suspicions and meet criteria, then you would refer using the 2-week rule to see a specialist. Of course, first line here would be a chest x-ray, and this may show things such as a peripheral circular opacity, hilar enlargement, consolidation, pleural effusions, or bony secondaries, which may all indicate the presence of a lung cancer. Moving on from here, you'd do a contrast-enhanced CT scan, and this would predominantly help you stage a tumour or find one if you hadn't seen one previously. Following that, you can do a bronchoscopy, and this would establish a histological diagnosis and assess operability as well. So this should be performed on patients with central lesions where nodal staging does not influence treatment. Bear in mind there are other investigations that you can do for a patient with lung cancer or suspected lung cancer, but these aren't listed here. These are just the main investigations you'd want to do. Bear in mind when thinking about patient management, you judge them based on performance status and not the cancer always itself. So 0 is able to carry out normal activities like yourself and me on a normal day-to-day basis, whereas 4 is completely disabled. And this allows you to gauge where the patient's at in terms of their functionality in day-to-day life and with aspects, ADLs, etc. So management, if the prognosis is potentially good, I mean, an important thing here would be to stop smoking, especially if smoking is likely the cause. Even if prognosis is fairly bad, I mean, stopping smoking may lengthen their prognosis. Surgery may be an option, based of course on the type of cancer. Performance status of the patient will all play into this decision. So the treatment of choice for patients with stage 1 or stage 2 disease would be a lobar resection. Next we have radiotherapy. This should be offered to all patients with stage 1 to 3 non-small cell lung cancers who are not suitable for surgery, and you've also got chemotherapy as well as an option. There's also new medications that are available, but these are quite specialist and certainly not something you'd be expected to prescribe as a junior doctor, and therefore it's worth having an understanding that there is alternative ways to manage lung cancer and not just for surgery, radiotherapy, chemotherapy. These tend to be quite specific to certain types of cancer. So in summary, we look at the questions we've already looked at the start. So if you've got a patient with hyponatremia, remember the most likely diagnosis here is small cell lung cancer, on the basis that this is likely to be a paraneoplastic syndrome resulting in the production of ADH and as a result hyponatremia. Question 2, a non-smoker diagnosed with lung cancer. Of course here the most likely answer is adenocarcinoma. This is the most likely cancer associated with non-smokers. And finally, a patient with performance status of 3 is most likely to be able to do limited self-care, and it's important to keep in mind the performance status when you diagnose a patient and are deciding on their management. Okay, thank you very much for listening. If you do have any questions, please feel free to get in touch, and I hope you found this video useful.